Welcome everyone to the HLH Symposium, Expanding and Refining Our Understanding of Harmful Immune Activation. We're starting 10 minutes late. We won't cut the talk short. We'll just take a little bit out of our next coffee break. There's a few people who are still finishing lunch, but it is my pleasure to introduce Joe Carcillo from the University of Pittsburgh in the USA, who's going to speak about hyperferritinemic sepsis and multi-system organ dysfunction syndrome. Yours.
Can you hear me?
Are you able to hear him?
Can you hear me speak? Yes, good, perfect. Well, let me see a show of hands. How many of you have been consulted to see a patient in the ICU? Okay, this talk is for what to think about when you go to the ICU, because the work of this society has really moved you from the outpatient clinics to the ICU if you have an inpatient practice, more than it has in the past. I'd truly like to thank the Society for inviting me. It's really a great honor. I don't see the talk on this, so I'll look up here. I'm not trying to be impolite. Okay, so this, in 2009, after the criteria were published for HLH, the 5 of 7 criteria, we published this piece saying that actually these same characteristics are present in patients who have sepsis. And ICU doctors will define sepsis as organ failure suspected to be related to infection. And then if there's more than one organ failure, ICU doctors call that sepsis with MODS. And you can see that every one of the criteria for HLH have been reported in that condition. And when you look at sepsis, this is the model published by Dr. Carl and Dr. Hotchkiss of how people think about sepsis. You have an infection, you interact with the innate immune system, eventually bringing on the T cell system. And the idea is that apoptotic bodies will cause T cell exhaustion, whereas necrotic bodies or necrotic tissue will cause T cell and macrophage activation. So you get a cytokine storm that has a combination of anti and pro-inflammatory condition. The NK cell itself initially is activated when you have a local infection, and then over time in the process, the NK cell itself becomes deactivated. Now in sepsis, it's oftentimes related to apoptosis, so the actual number of NK cells go down. And so the lack of cytolytic activity is not related to cytolytic activity per se per cell, as it is with HLH, but rather a reduction in cells. And here you can see we looked at 45 children in our ICU, and on the left you can see a reduced number of cytotoxic cells. The pediatric sepsis patients are the black circles. The open are the control, and then the adults. And then on the right, what you can see is, however, that the number, the cytolytic activity per cell is actually the same. So this reduction in NK cytolytic activity that can lead to T cell activation, inability to fight viruses, cancer cells, et cetera, is the same, but not related to a qualitative defect, but a quantitative defect. This is a paper that I think helps me understand most in rodents what the difference is between sepsis-induced, what I call, we'll talk about it, macrophage activation syndrome, but one would call secondary HLH. And this is Dr. Ruslan Mechtoff, who is a Howard Hughes immunobiologist at Yale University, who you may or may not know. But he calls this the SHLH phenotype of the severe sepsis syndrome. And in this, what he's shown is that if you take rodents, it's the sequence of antigen. Virus, bacteria, or bacteria-virus gives you one cytokine and 5 of 7 criteria approach. But if you do virus, then bacteria, so viral priming, you get the other. And here what you can see is if you go over A, which is ferritin, B, which is triglyceride, C is liver, D is cytopenia, E is anemia, F is thrombocytopenia, G is SCD25, or soluble IL-2 receptor. And then H is a quantitative HLH score with pictures of the hemophagocytosis. What you can see is if you give a virus and then a bacteria, that's when your ferritin levels are up over 2,000. And I'm just going to focus you there. I can tell you, you can look at the rest. It's exactly the secondary HLH syndrome. But I'm going to focus on that 2,000. It will become apparent to you later, because that is the cutoff we are using in our now 1,000-patient multi-center trial, which started 2 weeks ago. So the way we would interpret this with Dr. Graham's model here of a SHLH MAS picture is in the MAS HLH picture, you have a decrease in the NK cytolytic function, but in sepsis, you just have a reduction in the number of cells. But you still get the same overall picture, except we don't see any proliferation of CD8 cells in sepsis. We actually have apoptosis of our T cells. And so that's the difference. And I published this if you want to read it. If you like clinical vignettes, I give 6 clinical vignettes. If you'd like to look at this, it's a real quick read about how we as intensivists look at a patient and decide whether to call you or not. But essentially, in the right upper corner is the familial HLH. You can see the NK cell numbers are normal. They're white, meaning they have no activity. It could be, as Dr. Henter said, related to perforin or export. And then you get a proliferation of CD8 cells, or it could be CD19 or CD20 cells, depending on your immunoproliferative phase. As you migrate your eye down in purple, you see what happens with cancer. You have lymphoproliferative disease. That lymphoproliferation itself can cause interferon gamma production. But as a word to the wise, all the work that was done in neutropenic sepsis, the patients we see, when you wait for the neutropenia to recover, there's still NK-penia. So the other thing that can be happening here is that your NK cells are like sepsis, less than 10%. That can be found with an NK cell count. Next is the MAS of rheumatology, where the NK cell number and CD8 cell number are normal, but it's not complete absence of cytolytic activity, just reduced. And then at the top is sepsis. And in sepsis, we have normal NK cell activity per cell, just not very many cells, 1 compared to the 2. And not very many CD8 cells, just 1 compared to the 2. So now that I said that, you say, Joe, where did that come from? Here's the data. So in 1988, it was first reported in adult sepsis MODS patients, hyperplastic, hemophagocytic histiocytosis syndrome, or triple H, they called it. And there are 3 papers. These are done in adults looking at their autopsies. And you can see they have normocellular, severe, and hypocellular is how they talked about it. The hypocellular had the worst outcome. And when you look at the things that it's related to at autopsy, if you do not have HH on the left, and if you have mild or severe on the right, at the top what you can see, it's younger patients who die with HHH compared to without HHH. As you train your eye down, you can see that the length of stay in the ICU in the hospital is longer. The presence of sepsis and infections is greater. Cardiovascular disorders are less. So the cardiovascular patients in the ICU are not these patients. It's the ones with sepsis. And when you look at cause of death, their cause of death is from sepsis, respiratory failure, and multiple organ failure, and not from respiratory failure. I'm sorry, cardiovascular failure. Now, unlike HLH, the major driver of this besides sepsis is blood transfusions. Because what you're doing in this syndrome is you're feeding the hemophagocytosis through the CD163 receptor. That can be driven by disseminated intravascular coagulation, which occurs in sepsis. You can think of it as a reticular endothelial system activation, or by sepsis. And it's the number of blood transfusions. The more blood transfusions you receive, the more likely you are to get the syndrome. When you look at the cytokines of these patients with HHH, you can see a significant difference in IL-6 and IL-8 levels. But when you look at the correlations below, importantly, you'll see that IL-1 beta correlates with TNF, IL-10, and IL-8. And this is important again for the trial I'll talk to you about at the end of the talk. So the first thing we did was I met Dr. Jordan, and I think it was an ACR meeting. He presented his beautiful work. I was really excited about it, talked to him about it, and asked him, does he think that this applies to sepsis? At the same time, Dr. Krohn had asked me to come after we published this paper, and his answer was, I don't know, so neither did I. So I've spent all the time since then studying the question, and I still don't know the answer, just so you know. But anyway, we went back to the clinical trial in the 90s of anakinra in septic shock. So this is a 1,000-patient anakinra septic shock trial, and Dr. Bidashakuri, who was Dr. Krohn's fellow, she used Ravelli's criteria and picked 2 organ failures most predictive of MAS or SHLH, and those were hepatobiliary dysfunction and DIC. And when we broke out the patients, we found that 6% of the patients with adult septic shock had those criteria. That fits the autopsies that were presented in the Suster and prior HHH, so very indicative of the histologic findings. And when we broke it into those who received anakinra versus placebo, we completely ablated the mortality associated with that condition. In other words, we brought the mortality or the survival to be equal to patients who did not have combined hepatobiliary dysfunction and DIC, suggesting that anakinra was curative for that MAS, now people say MALS, you guys call it secondary HLH syndrome, but has no effect in the rest of the population. Importantly for us, since this is hyperferritinemic sepsis, when we broke it out, it was a ferritin level of 2,000 where we saw the effect. So you can go to the bedside, and if your ferritin's over 2,000, or you have combined hepatobiliary dysfunction, or DIC, and the combination combined, right, and not or DIC, then anakinra might be the answer. So many people said, well, how can you use HBD DIC? We don't believe it. So we've now done a series of those studies. This looks at a second independent cohort. This is called the process trial, another 1,000 patients. This was looking at different types of resuscitation early on. And we again found that only 6% of those patients had combined hepatobiliary dysfunction and DIC. And when we looked at the cytokine pattern is exactly predictive of macrophage activation. It's associated with a higher 90% mortality, and that mortality is related to hyperferritinemia. Now, is it possible that genetics are driving this condition? So we took the 6 patients out of that 1,000 who had combined DIC and hepatobiliary dysfunction and had the highest ferritin levels. So we're looking at 0.5% of that 1,300 patients. And then we did whole exomes, looking for non-synonymous variants, minor allele frequency less than 5%, and looked for exact nucleotide change previously reported as causal for the following diseases: HLH MAS, SCID, CVID, ALPS, WHIMS, PIK3K, AHUS, PFS, and other primary immune deficiencies. This work was all done by my colleague Kate Kiernan, who gives her apologies for not being able to be here today. And when she looked at these 6 patients, every one of them had a pathogenic variant related to that process. Now, important to me, on the left you can see C3, UNC13D, CD46, CFHR5, UNC13D, NLRP3, MEFV, UNC13D, CD46, and MEFV. So autoinflammatory conditions, immune dysregulation conditions, and hypercomplementemia conditions. And I'm an intensivist, so if you look to the right, I just care about treating patients. And so what you can see is eculizumab, anakinra, eculizumab, anakinra, 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 eculizumab, and anakinra. There would be a biologic basis for treating all those patients. Now, our colleagues in Greece and the Scandinavian Consortium wanted to prove what we showed, and they did a derivation, and they did a validation, thousands of patients, and they again found that the combination of hepatobiliary dysfunction and DIC predicted in this case, 4% of the population, but with the highest mortality. And they looked at the cytokines, and you can see they have higher IL-6, they have a higher IL-10 to TNF ratio, meaning more of an anti-inflammatory ratio, more IL-18, more interferon gamma, more SCD163. And then they asked the question, how should we organize our trial? Can we organize it to ferritin levels? And on the right, you can see that they found that a ferritin in adults, over 4,400, actually 4,430 predicted outcome, and a less than 15% drop in that ferritin level at 10 days was associated with mortality. And they are presently doing the clinical trial, if you want to look it up, it's there in the NCT, where they are randomizing these patients to anakinra versus placebo. Okay, what are the clinical and genetic studies in children? So if you go from top to bottom, top is looking at patients with a ferritin less than 500, and they're in dark black, compared to those with a ferritin 500 to 1,000. And then next is in black again, less than 500, but compared to 1,000 to 3,000, and next compared to 3,000 to 10,000, and then greater than 10,000. And in the red box, you see hematologic failure, or DIC, and hepatobiliary dysfunction. And you can see as the ferritin levels go up, compared to those black boxes, that combined organ failure goes up. So this is showing you in pediatric sepsis that this MODS pattern increases as ferritin goes up. And on the right, we're showing you CD168 stains, H-ferritin stains. I'm not showing the L-ferritin. And of the 30 children that we had that we looked at, 1/4 of them had CD8 cells or CD19, CD20 cells. So 75% of the children that are in our sepsis cohort who show this have do not have lymphoproliferation, which I call macrophage activation, and then 25% have, which I call HLH. So we next did a trial with Dr. Demirkol in Turkey, which is a randomized cluster trial of 4 centers. All of these children had hyperferritinemia with the diagnosis of secondary HLH, sepsis, MODS, MAS. The median ferritin level was 6,000. The median number of organ failures was 5, so 5 organ failure. In univariate and multivariate analysis demonstrated that use of plasma exchange with methylprednisolone or intravenous immunoglobulin, they had 100% survival. When they used chemotherapy, cyclosporin, or etoposide in 6, it was 50% survival. So when you look at these patients, 100% of these patients had fever, 100% had hemophagocytosis, 100% had hyperferritinemia. So really, for all intents and purposes in the ICU, it's hyperferritinemia. So that's why we call it hyperferritinemic sepsis. When you receive plasma exchange, if you look at the top box, thank you. If you look at the top box, you can see that the ferritin levels come down by day 4 from over 20,000 to less than 1,000, and then by day 5 to less than 500. You can see the thrombocytopenia increases by day 5 to being over 100,000, and the LDH comes down as well. At autopsy, the children who received chemotherapy, the 50% who died, all had persistent fungal or bacterial infection on their histology. This is unpublished data, but we had a little more resources than we had in Turkey, and this is a child who we treated for 7 days with plasma exchange. And this is just to show you that the NK cell activity recovered in this sepsis patient over the 7 days from less than 10% to over 60%. So that would not happen if you had primary HLH. You can't recover with plasma exchange, that activity. And we use an ex vivo TNF response. We take your whole blood, we expose it to endotoxin, and then we look at how much TNF your whole blood makes. If it's less than 200, you cannot fight bacterial infection. If it's more than 200, you can. So again, the plasma exchange with IVIG and Cymedrol, we saw a recovery of the ability to fight infection, and then you can see the ferritin came down. So it worked in our hands as it did in the hands of the Turks. Now, when we look at sepsis, we think of 4 phenotypes, and they all lead or are themselves macrophage activation syndrome. First is immune paralysis. If you're training your eyes to the top, what you can see is that a patient who has persistent or recurrent infections, when you look at their ex vivo TNF response, they can't fight infection. And when you look at their autopsies, on the right, you'll see Herc staining with lymphocyte apoptosis on the left. On the far left, you're seeing a patient who died of SIDS. And there you see very nice follicles in the lymph node, the thymus, and the spleen. And then you can see just to the right of that patient, no follicle at all. So when you look at these patients at autopsy, they have no lymphoid follicles. They're gone. They have complete lymphoid depletion. That's why they can't fight infection. When you train your eye to the left lower corner, we also see a thrombotic microangiopathy phenotype. This can be recognized by acute kidney injury with thrombocytopenia and an Adams 13 level less than 57%. And when you train your eyes here, we look at brain, then kidney, then lung. You can see the upper is H&E staining. It's normal. But when you stain for von Willebrand fragment multimers, you can see the microvascular thrombi. You need to do that to see it. In the lower right-hand corner, we called this sequential multiple organ failure. We wrote this paper before the term HLH came out. And this is a viral lymphoproliferative disease. And I believe this is the pure primary HLH. This is driven by viruses and associated lymphoproliferation. Now, importantly, all of these lead to macrophage activation syndrome, which we define by hyperferritinemic, hepatobiliary dysfunction, and DIC. And the treatments are, for immune paralysis above, we give GM-CSF. For thrombotic microangiopathy, we give plasma exchange. If they're on a CRT, we'll add eculizumab if we can't get them off. For the sequential multiple organ failure kids, we call you. And then for the macrophage activation syndrome, we give steroids, IVIG, plasma exchange, and call you. So now the question is, we are a clinical trials network funded by the NICHD. And so we want to find out, can we do studies on this? So we enrolled 1,000 patients, and after all exclusions of these severe sepsis patients who have an A line and a central line, we wind up with 401. And of those 401 patients, 100 or so have single organ failure, and 300 or so have multiple organ failure. And of those 300 or so who have multiple organ failure, 100 have immune paralysis, thrombotic microangiopathy, lymphoproliferative disease, or MAS. Now, this is showing you ferritin and CRP levels. So when you're called to the ICU, if you look at the ferritin and CRP levels, you can immediately tell if the patient's sick or not. What you can see is on single organ failure, the ferritin level is 184. When you look at this ferritin at the CRP, it's 12. But when you have multiple organ failure with any of these phenotypes, you can see that the ferritin level goes up from 184 to 694 as a median. And when you go for a CRP, you can see it goes from 12 to 21. Importantly, when you're called for multiple organ failure that isn't one of these phenotypes that feed into MAS or HLH, depending on your kid, you'll see that the ferritin level is normal. So the ferritin level is not higher. So you need to have a higher ferritin level and a higher CRP level to look at it in your patients. And when we look at the risk factor of developing macrophage activation syndrome, kids with single organ failure in the ICU do not develop it. Patients with multiple organ failure without any of these phenotypes do not. And the patients with the phenotype have a 7 times odds risk. The immune paralyzed, the immune depressed, 7-fold time. The kids with thrombotic microangiopathy, 14-fold. And the respiratory failure that then develops liver failure with high soluble fast ligand, they have it 100% of the time. That is your primary HLH kids. Now, I told you that each of these phenotypes leads to MAS And in intensive care, we only care if you live or die. We're kind of very focused that way. So if you look at the immune-depressed patients in IPMOF, what you can see is that 1 in 5 will go on to develop MAS, and the mortality rate is 40% if you develop that, compared to 19% if you don't. So we're all about that, and that's what our clinical trial is, which I'll talk to you about. If you look at the thrombotic microangiopathy, the TAMOF group, you can see that 1 in 3 patients to 2 in 5 patients who have that will go on to develop MAS, but their mortality rate with MAS is not different. So in these kids, we have to focus not only on the MAS, but also on the thrombotic microangiopathy. And then when you go to the SMOF patients, you can see they all are MAS, so we have to focus on MAS. Now, what's the relationship? What gives with hyperferritinemia and inflammation? How is it different? Why are we focused on that perhaps more than you are? You're focused on interferon gamma, for example, or other things. Because what's driving it in sepsis is the free hemoglobin. So free hemoglobin is attaching to the CD163 receptor and driving that. And when that drives that drives ferritin. And it drives ferritin through the iron-responsive element. Then there's the other aspect, which you guys are much more focused on, which is DAMPs, which are we call damage-associated molecular patterns, viral, microbial, and host DNA. And that stimulates NF-kappa beta. And that combination of combined NF-kappa beta and IRE together is what causes hyperferritinemia. Now, an increase in ferritin is protective in sepsis, but when you get too much of an increase, it can become harmful. And the reason it becomes harmful is ferritin itself induces inflammation in the liver, leading to liver failure. That's the hepatobiliary dysfunction in the yellow box, but also immune depression, so immune paralysis. So if I can't fight infection, my liver's failing and my endothelium is gone, I'll show you a causal analysis of what happens in a little bit. So let's look at the same group of patients. So it's the same group of patients that I just showed you all these phenotypes in. And if you train your eye on the left, you can see we do the ferritin cutoffs again. Remember I said to you, as the amount of ferritin goes up, you get more of that pattern of hepatobiliary dysfunction, DIC. You can see that most of the patients have a ferritin less than 500. So 71% have a ferritin less than 500. But 4% are over 10,000, 5% are over 3,000, 8% over 1,000, 13% over 500. That means that you're going to potentially be called on one of 3 sepsis patients in an ICU. Sepsis is the leading cause of death globally in adults and in kids. And the adults have even higher percentages of hyperferritinemia. So this is no joke, okay? I mean, in other words, this is not like some small group of patients if we use ferritin. Again, if you use the hepatobiliary dysfunction DIC, then you're down to 3 to 6%. So you have to think as a group where you want to go with this. When you look at that combined DIC and hepatobiliary dysfunction on the other side, you can see it's 9% meet that. Why does it matter? If you look in red, red is danger, green is go, and green light, red light, you can see mortality rate go up as your hyperferritinemia goes up. If you look at MAS, you can see it going up. If you look at below at viral DNA anemia, you can see viral DNA anemia going up. So the higher the ferritin in sepsis patients, more death, more DNA viruses. So this is the question. Take a second to look for your favorite cytokine. It's up there. So if you look at the top, I'll say it quickly, SCD163, IL-18 binding protein, CXCL10, IL-6, SCF, TNF, MCP, IL-2RA or SCD25, IL-16, MIP1, MCSF, IL-10, CXCL9, MCP, IL-8. Familiar? So as the ferritin levels go up, and you can see it below, less than 500 versus the others, it goes up. Now, for those of you who aren't familiar with this kind of heat map, white means you're at the median for the whole population. Red means you're higher than the median, and blue means you're lower. So you can see that as your ferritin levels go up with sepsis or you develop MAS, you have more inflammation related to macrophage activation, but look at the blue for a second. If you look at the bottom line, which is the immune depression, you could see that as your ferritins go up or develop MAS, you can't fight infection. So you're not only inflamed, you can't kill bacterial infection. If you train your eye up just a bit higher to Adams 13, you can't really see it, it's not blue enough, but you also develop thrombotic microangiopathy. Now this is called causal inference. Our colleague, I thought he was going to talk about this in a systems biology talk, but essentially you can now use mathematical techniques to at least get inference, causal inference. So we took all 34 cytokines, all 7 DNA viruses, and then we look at the outcome of MAS and death. And what you see here is there's a direct causal pathway of MAS to death. There's a direct causal pathway of MCP1, CCL2 to death. And there's a direct causal pathway of ferritin to death. The other thing you see is there's a direct causal pathway of ferritin to a low ex vivo TNF response, meaning the inability to fight infection. Now, to the right of that, you see several cytokines that live in reticular cells, macrophages, and dendritic cells, and also live in endothelial cells. And so it's telling you that reticular endothelial activation, as marked by IL-8, IL-18 binding protein, SCD163, are driving MAS and ferritin. And of course, MCP1, CCL2 is the monocyte chemoattractant protein, which is important for bringing in monocytes to macrophages. So really, this is giving you causal inference. And importantly to us, it's telling us that our approach to going after ferritin is accurate because really, MAS is called a confounder because it both increases death and ferritin. MCP1 is a confounder because it increases death and ferritin. Only ferritin sits there by itself as a causal analysis. So we're focused on ferritin. Could this be genetically driven? So we take the same 401 kids, and there were 71 where their lymphocyte counts were too low for us to get DNA. So I don't know about the sickest kids. But of the remaining kids, Dr. Kiernan, again, this time the Immunologic Society or Union of Immunologic Societies has now, every 2 years, they're publishing what they consider genes, monogenic disorders related to immune deficiency. And she took those 331 kids, identified those genes, looked for those with less than 0.05, again for missense, nonsense, frame shift, start site, or splice site, and then used a tool that geneticists use, which is called HGMD. This is a clinical database, so if you're a clinical geneticist and you want to say whether or not your patient might have a genetic disease, it gives you high probability of being causal. So she looked at that, and then she looked for inheritance pattern. 2 variants if it's autosomal recessive, 1 variant if autosomal dominant or X-linked recessive. And the first thing we found was that 61% of sepsis children have 1 or more of these variants. So these pathogenic variants are very common in sepsis children. And there is a racial component to it in the US. So African Americans are twice as likely as non-African American children in the US to have these disorders. Mostly for the African Americans, it's related to hypercomplementemia. There's some evidence that hypercomplementemia protects you in endemic meningococcal populations. We think that's probably what it is. But importantly, ECMO, you were over 4 times more likely to require ECMO if you had these variants than not. And ECMO, for those who don't know, is a cardiopulmonary bypass machine when you're in the ICU. Now, these are reflective. I don't think you can see them, but in blue are the complement disorders. In yellow are the autoinflammatory disorders. In gray are called the syndromic disorders. In green are the phagocyte disorders. Your favorite in the kind of the light brown are the immune dysregulation disorders. The purple disorders are the innate immune system. The antibody, cellular immunity, and bone marrow forms are next. So you can see that many of the variants that are reported in the HLH literature are also found in this paper. Doesn't matter. For those of you who don't know, this is called a forest plot. So you look at the odds ratio, and if you look at the top line, it's saying if you're culture negative, you're less likely to have any of these variants. And if you're culture positive, you're more likely. So that gives us biological feasibility in us saying that this means something. Because if you have sepsis, and sepsis comes from infections, we would expect that a primary immune deficiency variant would be seen more commonly if you were culture positive. And importantly for us, these are the inflammatory markers. Then if you look at ferritin over 500, CRP over 10, thrombocytopenia and lymphopenia, and these are the markers of the 4 phenotypes I showed you as well as MAS, you can see that your odds ratio is high for having these pathogenic variants. So immune deficiency variants are more common if you're hyperinflamed with sepsis. And then I think this is most important to the crowd today, just to take a minute. On the y-axis, you have cellular and humoral, then antibody, then bone marrow. Then you have dysregulation, phagocytes, innate, combined syndromic, autoinflammatory, complement, multiple variants, and single variants. And then on the x-axis, you have culture negative, blood culture positive, respiratory culture positive, urine culture positive, and then in the box, hyperferritinemia. And what you can see here is that hyperferritinemia in sepsis has an increased odds ratio of immune dysregulation, innate immunity, combined syndrome, and complement variants. So it suggests that what we're seeing has biological plausibility and that there are therapies to treat it. Now, this is the clinical trial we started 2 weeks ago. And this is a 1,000-patient, 24-center study funded by the National Institute of Child Health and Development. So the concept here is that if you have sepsis, you might have too much inflammation, which is causing immune depression, or you might have not enough immune function that's causing hyperinflammation. So if you want to get your inflammation and immunity just right to kill infection without hyperinflammation, then the hyperinflamed, you're going to give something to reduce inflammation. And then those are immune depressed, not from hyperinflammation, but from other factors. You're going to boost that immune system. Here we show you in children who have ferritin levels less than 2,000 and an ex vivo TNF response less than 200. If you give them GM-CSF, granulocyte macrophage colony stimulating factor, you can stimulate their ex vivo TNF response on the left. And then when you look at the systemic cytokines on your right, you can see the cytokines come down. So when you treat these children with GM-CSF, you reduce their ferritin levels. You reduce their IL-6 levels, and you reduce their IL-8 levels, while in the monocyte itself improving its ability to kill infection. Now here's a child with a ferritin level over 2,000, and here in this child we give anakinra to reduce the inflammation, to reduce the ferritin. And when we do that, you can see the ex vivo TNF response to the monocyte recovers so the child can fight the infection. So this is called the PRECISE trial. It started 2 weeks ago. It's an embedded trial. If you would like to look it up, here's the NCT number. It's 2 trials. GRACE is for those children who have an ex vivo TNF response less than 200 and a ferritin level less than 2,000. And then TRIPS is for children who have a ferritin between 2,000 to 10,000, or 500 to 2,000 with an ex vivo less than 200. And I want you to notice we are leaving out those over 10,000 from the study because there doesn't seem, you'll have to help me with this, but there didn't seem to be comfort in studying these children. So over 10,000, if over 10,000, they're just observed. But in the other groups, they'll be being treated with for immune paralysis or anakinra. The outcome will be reduction in multiple organ dysfunction, and hopefully we'll have answers for you in 5 years. I really thank you for your time, It's been a pleasure and really such a great honor. And I want to tell you that I am truly inspired by your work. And I think it's helping kids not only that you follow, but also I think it's helping us a lot in the ICU and sepsis. I'd like to thank my collaborators. This is funded by 2 NIH grants from National Institute of Child Health and the NIGMS. And my collaborators include those from the Human Genetics Department, Computer Science, my K-12, Kate Kiernan, our collaborative workers, Scott Cannon at the University of Pennsylvania and the University of Utah. And that's where I've been the last 15 years. Thank you very much.
Thank you so much, Joe. That was fantastic. I think we have time for maybe one question.
Thanks, Joe. Great presentation. Look, what happens to patients who already have a high ferritin level to start off with? In other words, hemochromatosis, and are they at higher risk of getting, catastrophic sepsis? Because my impression is they're not.
No, that's a great question. So I didn't mention this, but if they have a high ferritin, we look at their iron saturation, and if they actually are iron overload, we chelate them. We don't put them through this protocol. But to answer your question, patients with hyperferritinemia, even related to iron overload, are more likely to die from sepsis.
So you're saying if they've got a high ferritin but low transferrin saturation?
Right. So in other words, this is not an iron overload. So in acute, it can be being driven by iron coming from red cells that are breaking up, but it's not iron overload secondary to hemochromatosis. These patients have normal or low iron stores. Thanks for that clarification.
Thank you so much. Next, we have Dr. David Teachey from Children's Hospital of Philadelphia, who's going to speak about hyperinflammation, cytokine release syndrome, and HLH with CAR T-cell therapy. Thanks, Dave.
Thank you very much. I'd like to first thank the organizers for having me out here to speak today. I always enjoy coming to this meeting. I think it's a fantastic blend of clinical vignettes, basic science, and translational medicine that always makes it very educational. I'm going to talk today, as just mentioned by Michelle, about CAR T hyperinflammation and HLH. Lots of disclosures. I'm not going to read them. Today, I'm going to talk about acute lymphoblastic leukemia primarily a little bit, so a little bit different as far as a topic. I think that the cure rates for acute lymphoblastic leukemia are one of the great success stories in modern medicine, and most of how we got here historically is by using drugs that were developed between the 1950s and 1979. However, the field has recently changed quite a bit. In this very US-centric slide about FDA-approved drugs, recently there's been a number of immunotherapies, including naked monoclonal antibodies, bispecific T-cell engagers, and CAR T-cells that have gotten approved for use in kids for ALL. The concept of treating patients with CAR T-cells goes back to the 1980s, and the initial trials that used them actually failed because they didn't include a co-stimulatory domain. And really the big breakthrough in the science that allowed these to start working was to actually include that in the development of the CAR T-cells. The early trials, the CAR T would bind to its target, and then the T-cell would kill it but undergo anergy. And with the inclusion of a co-stimulatory domain, it binds to its target, and then it proliferates and can kill more targets. The downside of that proliferation, though, is some patients get cytokine release syndrome, which I'll talk about today. We've been using CAR T-cells in the clinic now for 10 years. The first reports of 10-year survivors were just recently published. Got a lot of buzz in the news. This is showing some of the international data from the Eliana trial that shows that a lot of patients with highly refractory B-cell acute lymphoblastic leukemia respond to CAR T-cell therapy. There's lots of CARs out there. The data look pretty similar across the board, that these are highly effective in B-cell ALL. And this has actually led to FDA approval of now, this slide's already out of date, even though it's pretty new, of 7 different CAR T-cell products are approved in the US. They're not quite as many that are approved outside of the US, but it's getting there. My goal today, though, is really not to talk about the efficacy of CAR T cells. It's really to talk about the toxicity of CAR T cells and how it may be of interest to this group, and most of it's going to be focused on cytokine release syndrome. So cytokine release syndrome occurs after a lot of immunotherapies and can be very mild with fever and flu-like symptoms to being very severe, where patients can get critically ill and dying in the ICU. This is showing some early data on just a handful of patients who got critically ill with CAR T cells, and the data look exactly the same. If I increase this to hundreds of patients, it's looking at over time, and this is using a CD19 CAR with 4-1BB co-stimulatory domain, Teachey. And as you can see here in critically ill patients, often they start with getting fevers, and then they get cardiovascular collapse pretty early. They develop shock. After getting shock, they get end organ damage, often because they have significant capillary leak, with renal dysfunction, hepatic dysfunction, and respiratory failure. One thing that we noticed pretty early on after treating patients with CAR T cells is they can get a coagulopathy, very similar to HLH, and they get a hypofibrinogenemia that's markedly out of context or out of proportion of the rest of their coagulopathy. And this tends to be a late manifestation, so patients are getting better, and then they start developing hyperfibrinogenemia. There's been a lot of groups, including my own, that have tried to find biomarkers that are associated with severe CRS. I'll kind of walk through this. There are other slides that use the same kind of presentation, where there's patients, the highest value over the first month is depicted by a dot for a patient, breaking down patients into did not get severe CRS or critically ill versus did get severe CRS. Sloan Kettering was the first group that started looking at getting CRP in these patients. Not surprisingly now that they were highly elevated in patients who got critically ill, but at the time it was. These patients get high IL-6. Our group was the first one to really start looking at ferritins in these patients. They tend to get very high in patients with and without severe CRS, but they get higher in patients who get severe CRS. And probably one of the best surrogates we have right now of who's going to get critically ill is disease burden. And this was an early observation that if you walk into CAR T cells with very little disease burden, the odds of getting critically ill are very low. There are outliers. In contrast, if you go into CAR T cells with high disease burden, it's about a flip a coin if you're going to get critically ill. And it really depends on the CAR you're getting and the patient population as far as the absolute risk. But there definitely is a correlation with disease burden. This has been shown now in a couple different studies. These are two studies that were just published in this past year in the Journal of Clinical Oncology. The one on the left was looking at 200 different patients with real-world data of Teachey. The slide on the, or the figures on the right are looking at 400 different patients treated with 3 different CAR T cells. And it basically showed the same thing, that patients who walk into CAR T cells with high disease burden are more likely to get critically ill with severe CRS. They're also more likely to get neurotoxicity. And what was kind of alluded to in the literature but not proven at the time was that patients who have high disease burden and get critically ill actually have a less likely chance of actually having a good response to the CAR T cell therapy. My lab has been interested in studying CRS biologically for a number of years. This is showing some of the early data. So after we had treated 51 patients or so with CAR T cells, we looked at cytokine profiling. We looked at 43 different cytokines, chemokines, and soluble receptors using Luminex platform. Of those, 24 we found elevated in patients with severe CRS as compared to not severe CRS, and I'll walk through them. What was not surprising at the time was a lot of the cytokines that were elevated in patients treated with CAR T cells were cytokines that you'd be associated with activated T cells. What's not surprising now, but was highly surprising at the time, was a lot of the cytokines that were differentially elevated in patients with severe CRS are ones that are usually associated with activated macrophages. There were a couple that were associated with being chemotactic with macrophages. There were a lot that were nonspecific biomarkers of tissue damage and inflammation. And then 2, which I found interesting, which I'll get to later, were IL-10 and SGP-130. They're actually 2 of the first to go up after treatment of Teachey, negative regulators of different cytokine signaling. SGP-130 of IL-6, which I'll get to, is when we talk about how we treat severe CRS. The first patient we treated with CAR T cells became critically ill, and she looked like she had HLH. I still remember she was treated at the end of a week. Over a weekend, she developed massive hepatosplenomegaly and was dying in the ICU. On Monday, we had our stem cell transplant conference. It was described how she got massive hepatosplenomegaly overnight. I raised my hand and said, "This sounds like HLH." I was told I was crazy. The next day, she continued to get sicker. I said, "This really sounds like HLH." I was continued to be told I was crazy. And finally, I was pulled aside and said, if the first patient treated with CAR T cells has HLH, it'll kill the field. So then I drafted an email and I said, fine, she doesn't have HLH, I'm wrong, she has MAS. And everybody's like, oh, what's that? I kid you not. So we sent it, and they were like, how do you work that up? I'm like, well, you send a ferritin. We sent a ferritin, it was really high. And then we started looking more for HLH, or MAS, as it was called in this case at the time. Early severe CRS, and I'm going to distinguish that from other forms of CRS later, really is biologically HLH. This is showing some data where we group cytokines based on data in patients with HLH for cytokines that are elevated in patients with HLH are on the left, ones that are typically normal in HLH are on the right side, and ones that sometimes are elevated in HLH are in the middle. The red dots are the peak value in patients with severe CRS. The black dots were the highest value in patients without severe CRS. And I think the pattern kind of speaks for itself. Cytokines that are elevated in HLH are elevated in cytokine release syndrome. Ones that are not elevated in HLH are not. I made a graph of CXCL9 because I know how much that is loved by this group. And as you can see, CXCL9 goes up after treatment of CAR T cells and comes back down. More recently, we decided to take this to the next step and actually look at severe CRS at a more global proteomic level. This is work that was just published this month by Carolyn DeOrio and Ron Traim. For this, we use the Olink platform. This is a platform that uses a proximal extension assay and basically takes a labeled antibody bound to an oligo that binds to a protein and then basically uses the equivalent of a PCR reaction to amplify it up. And it allows you to measure hundreds or thousands of proteins in a very little amount of blood. So this is data looking at 1,463-ish proteins in like 50 microliters of blood from over 20 patients treated with CAR T cells, broken down by proteins that were differentially high in patients with severe versus not severe CRS. We took that data, we plugged it into KEGG, and then the pathways that were most commonly dysregulated were, of course, cytokine signaling. But we wanted to actually look to see more globally is the proteomic profile in severe CRS similar to HLH. For this, there was a nice paper recently published by Mike Jordan and Carl Allen where they actually looked at proteins in patients of HLH compared with those of sepsis. Nice data. We actually looked in the supplement there, pulled out the proteins that were elevated in that cohort in patients that were kind of high HLH biomarkers versus low HLH biomarkers, compared that to our data, and we found, again, on a larger scale, the proteins that are commonly elevated in HLH are commonly elevated in severe CRS, and vice versa. We recently sent our data set to Mike, and we'll be very curious to see the answer to this because he performed SOMA, which is a similar technology on a large number of proteins, and he's going to compare our severe CRS cohort to his genetic HLH cohort. And I hope it'll show the same kind of pattern, and if not, I'll take back everything I said. And then something we did very early on was if you just take the HLH 2004 criteria and plug in patients who have severe CRS, this is looking at a bunch of patients of grade 3 and 4 CRS, the overwhelming majority of patients clinically who are treated with CAR T cells, if you use that nomenclature, would meet the HLH criteria. There's been a lot of recent discussion on this concept of CAR HLH, which is getting HLH after treatment of CAR T cells. And I think Nirali Shah gave an excellent talk on it yesterday. Kevin McNerney is going to talk about it later today. I think you have to take this in context. My biggest worry with the term CAR HLH is the connotations that HLH has outside of this room, sometime in the field. And I also think that it can be tough to distinguish biologically and what does it really mean, and it depends on the CAR you're treating. So one definition of CAR HLH that's been published is high ferritin, organ toxicity, and supporting evidence of elevated biomarkers. When we looked at our data set, just in patients who had severe versus not severe CRS, using a ferritin cutoff of 10,000, that's often seen in both. If you look at which patients get transaminitis, we often see transaminitis even in patients who don't get critically ill after CAR T cells. If you look at soluble SIL2 levels at baseline, so this is pre-treatment, they're often highly elevated in patients with leukemia. And then if you look at CXCL9, that is often elevated both in patients who get critically ill with severe CRS and those who don't. In contrast, the data that I don't want to steal Kevin's thunder, but the data that Kevin's going to present later show that patients with CART19 who develop HLH-like features, who develop this criteria, do markedly worse. These patients have worse overall survival, and which really surprised me when I saw them present the data, is they have worse relapse-free survival. So they're not just dying of toxicity, they're actually dying of leukemia. So while the nomenclature, I may have some issues with the CAR HLH in this early severe CRS, trying to distinguish it, I do think it's very important data because it helps define a group of patients who, after CAR T-cell therapy, are more likely to have their leukemia come back and have a bad outcome. When Kevin looked and compared, actually, patients who had severe CRS who developed CAR HLH-like features versus those who didn't, their ferritins were higher, their CRPs were higher, and as I said, their outcomes were worse. The first kind of notion that there may be a different type of cytokine release syndrome that can happen after CAR T cells was the excellent work that was done by Nirali Shah and Terry Fry on some of the early data looking at CART22, or CAR T cells targeting CD22. And what they found in these patients are patients can get severe CRS that we see with CART19, but they can also get this second wave of a later CRS. So as patients are getting better from cytokine release syndrome, they can get sick again, and the biology of it's a little bit different. This is looking at some data that I'm not going to go through in much detail because it was showed yesterday, that some of the cytokines that you get in this later CAR HLH, or whatever you want to call it, I like the new nomenclature that I'll mention briefly, IECHS. The cytokines that get elevated are different. The biology is different. It's a little muddied by the fact that most of these patients have already had cytokine-directed therapy for their initial severe CRS. We know in the MAS population, if you treat with tocilizumab, it does change your cytokine milieu. But it does seem to be a different beast that we need to understand better. And based on this, Nirali with the ATSCT has put together a group of people, and I think it's a great group because it includes adult CAR T-cell specialists, pediatric CAR T-cell specialists, infectious disease doctors, and HLH experts to really understand the biology and the clinical manifestations after CAR T-cells to both characterize more early severe CRS and this later CRS that's getting recognized more and more, which has a working group goals to really standardize the nomenclature, understand more about the biology, try to distinguish it from severe CRS, develop a grading system, treatment algorithms, future research, and consensus guidelines. And really the area that's being focused on after lots of discussions is not what I talked about, the CD19 data, this early CRS that has a lot of HLH-like features and overlaps. It's really trying to concentrate on the later presentations of CRS that are often seen with CART22, but are also seen with CART19 in a subset of patients. So what about outside of the ALL world? So CARs are now being used to treat other diseases as well. I think one area that's getting a lot of interest is using BCMA CARs in patients with myeloma. There's been a couple of papers that have looked at this recently and also looked to see do they get HLH-like features. This is showing some of that data from across a group of papers, one of which they do get hypofibrinogenemia similar to the BLL patients treated with CD19 CAR that tends to be late. They do get elevated ferritins in patients who have severe or more severe cytokine release syndrome, similar to you see of CART19 or CART22. And they also get higher interferon gammas and soluble IL-2 receptors, the cytokines we think about in HLH-like biology. My primary interest, actually from my research lab, is in T-ALL. That's what I do most of my studies in. And finally, we're getting some CAR T-cells treating patients with T-ALL. Most of the data are coming out of China, and they're actually pretty exciting because unlike a lot of our AML CARs, which just don't work so far, the data from China with CAR T-cells for T-ALL look pretty encouraging. There was one paper recently published in JCO that 19 of 20 pretty refractory patients were treated with CART7 and did very well and went into remission. The cytokine profiling that's been studied and published in the supplements of some of these papers is very similar to what we see with CART19 and CART22. The same biomarkers, high ferritin, high IL-6, high interferon gamma, high IL-10, high ferritin, et cetera. So it seems to be a theme across cellular therapies. While there are differences in kinetics and degree, the biology is pretty similar across diseases, at least most of what's out in the literature. In addition to CAR T cells, we're seeing the same kind of stuff when we use bispecific T cell engagers. So blinatumomab was the first one of those to be clinically developed. It's basically an antibody that kind of brings CD3 cells in connection to CD19 cells. The first patient we treated with blinatumomab at CHOP became critically ill, of course, had to be the first one. We sent cytokine profiling on that patient and had an HLH-like biology, and other groups have expanded upon this that showed that patients treated with blinatumomab who get critically ill clinically and biologically get the same hypercytokine that you see after CAR T cells. More bites are coming into the clinic for lots of diseases, so I think this will be a theme we see across diseases with different bites. Another thing that we've been interested in looking at, are there any things that we can use to predict who's going to get critically ill after treatment of CAR T cells, beyond just disease burden? Are there biomarkers? So these data we're looking at, we looked at cytokines in the first few days after patients have treated with CAR T cells, before they became critically ill, but after the first fever. And we found that if you sent an IL-10 and a combination of disease burden was very good at differentiating patients who became critically ill versus didn't become critically ill. Some work that Caroline recently did was looking at that O-link data set. Before infusion, were there any proteins that were differentially elevated in patients who became critically ill as compared to those who didn't get critically ill? And the only one of 1,463 that actually fell out was MLR1, which is a mast cell protein. We're still trying to understand the biology of this more. If you look on the right side, that is MLR1 over time, where the blue lines are patients who did not get severe CRS. The red lines are ones who did get severe CRS. So the patients who get critically ill, they start off with high levels, and they do actually normalize with time. There's a little bit of a correlation between the MLR1 levels and disease burden, so it's a little bit nuanced, but there definitely are patients who had high MLR1s who get critically ill that had low disease burden. So how do we treat cytokine release syndrome in the clinic? Right now, the FDA-approved medicine for this, and the medicine that's most commonly used, is tocilizumab, an IL-6 receptor inhibitor. The first use of this was not based on compelling data. It was based on that's what we had at the time. So that same first patient I mentioned who was dying in the ICU, as I was talking to Steve Grupp about the whole MAS thing, he showed cytokine data. They had sent on her interferon gamma, her IL-6, and her IL-10 were high. I mentioned that in Japan they used IL-6 inhibitors to treat Castleman's disease, because I kind of run a little boutique Castleman clinic at CHOP. He called Carl June. Carl June said, "Oh, I've heard of that drug because I have a family member with JIA." So they made the decision to give tocilizumab to the child. Wasn't my decision. Turned out to be a good decision, and she got better with it. And now there's been lots of patients who've been treated with tocilizumab after CAR T cells for cytokine release syndrome. There are arguably better drugs out there for it, but tocilizumab works for most patients. If you treat patients treated with CAR T cells with tocilizumab, most of them do kind of like what's shown here, where pretty much almost instantaneously after they get it, their fevers get better, their cardiovascular compromise improves pretty quickly, and then their end organ damage slowly improves with time. We've looked at the biology of this a little bit to try to understand how it may work in severe CRS, and it's really through blocking trans IL-6 signaling. So IL-6 signals two ways. The classic way, cis signaling, is IL-6 binds to its receptor on cells. This isn't very common, actually. There's not IL-6 receptors only on a few cell types in the body, including hepatocytes. Most commonly, IL-6 signals for what's called trans signaling, and basically for that, IL-6 binds to soluble IL-6 receptor in your blood and then binds to GP130 on cell types. And that's actually what signals downstream through JAK-STAT signaling. So what people would think of as cytokine release syndrome activating JAK-STAT. The way that, I'm gonna have to wing it. Sorry, on there. That's weird. Sorry. The slides on that screen went away. Apologize. So what happens after we treat patients of CAR T cells, actually, and then the way that you prohibit IL-6 trans signaling is normally in our blood. We have high levels of soluble GP130 and soluble IL-6 receptor, which serve as a sink. And to get trans signaling, you have to have IL-6 levels that get higher than the sink. And what happens when you treat with tocilizumab is you actually cause an increase in SGP130 and soluble IL-6 receptor, which actually buffers the IL-6, and then eventually you have decrease in your IL-6 with time. There have been a couple studies that have recently looked to see if tocilizumab can be effective at treating severe CRS. Can it be used to prevent severe CRS? This is work that came out of Rebecca Gardner in Seattle, where initially their CRS management was that they would treat patients kind of like we do at CHOP and a lot of other centers when they became critically ill. They would give tocilizumab, and they decided to look a different way and say, let's look at patients and treat them after they've had persistent low-grade CRS, and they gave those patients tocilizumab, and they found that it did treat severe CRS or prevent severe CRS. It didn't impact the development of neurotoxicity, and it did not impact efficacy of the CAR T cells or CAR T cell persistence. There was a trial that got recently published that came out of CHOP that actually looked at this prospectively on a clinical trial. For this clinical trial, patients were divided into two cohorts based on disease burden at time of infusion. If they had less than 40% blast, they were given traditional CRS management, i.e. if you get critically ill, you treat. And for patients who had high disease burden, again, over 40%, for those patients, after the second fever, they intervened with tocilizumab. The trial was designed that if less than 1/3 of patients with high tumor burden developed severe CRS, they would call it a win, and 4 out of 15 did, which met that threshold. Importantly, what they found was that early tocilizumab didn't impact survival. Survival was worse in the high disease burden cohort, but compared to historical, it was as expected. It also didn't impact CAR T cell persistence or B cell aplasia. One thing that Nathan Singh with Dave Barrett did was try to understand more about the biology and where is the IL-6 actually made. If we can block IL-6 and it's not impacting the efficacy of the CAR T cells, where is it coming from? And for this, they did nanostring and transwell experiments to actually look at different cell populations to see what cytokines they were making. Interferon gamma, not surprisingly, is made by CAR T cells and antigen-presenting cells. IL-6, though, was not made by the CAR T cells. It was only made by antigen-presenting cells. And recently, there was some real-world experience published by the CIBMTR. They're starting now to collect data on patients who were treated with commercial CAR T cell products, showing that pretty much the things that we've seen in clinical trials are also showing up in real practice as well, that severe CRS happens in patients, and these patients are getting treated with tocilizumab and other agents and are actually responding very well. This was data in 500 patients with ALL and non-Hodgkin lymphoma. There are, as everybody in this room knows, there are lots of ways that you can treat hypercytokinemia, and there's lots of drugs that are out there. And I think there's a lot of ongoing studies and ongoing work to try to figure out, one, better ways to treat severe CRS, alternative ways to do it, and there are patients who fail tocilizumab. There are patients who need more than that, and are there better ways to treat it? And I'm going to run through some of the possible options and some of the data that are out there. As this room is very interested in, there's been some recent work looking at targeting interferon gamma. These are two studies that came out of Marcella Mouse's lab, which actually looked in multiple different ways in preclinical models. Can you target interferon gamma either by knocking it out, or using emapalumab, or using other antibody-mediated blockers, and does it impact the efficacy of CAR T cells in mouse models? The long and short of it was no in hematologic malignancies, but interesting, in solid tumors, they are more dependent on interferon gamma for efficacy of CAR T cells. So it looks like, at least based on preclinical data, you could target interferon gamma in heme malignancies, but probably can't do so as more CARs are moving into the clinic in solid tumors. Is there any data actually using emapalumab in the clinic? The answer is pretty much all anecdote. We've now treated at my center 5 different patients with emapalumab who had refractory CRS. Kevin McNerney, the same Kevin I mentioned earlier, published 1 case in Blood Cancer Discovery this year. Of the 5 patients we treated, 1 of them was critically ill on ECMO, had already started to herniate, and died about an hour after emapalumab, so I can't really comment on that patient. But the other 4 patients we treated with imipalumab had marked clinical improvement. 3 of those had failed toci, anakinra, and steroids before imipalumab, and 1 had failed toci and steroids before imipalumab. And similar to what we see in a lot of patients of tocilizumab in this small number of patients, anecdotally treated, they all got better pretty quickly. So this is just showing the cytokine profile in 1 patient. Thanks to the SARS-CoV-2 pandemic, we now have clinical cytokines that we can get with same-day turnaround at CHOP. That kind of pushed us over the finish line. So now patients that are getting critically ill, we're sending cytokines in clinical. The red arrows here were tocilizumab, where we were not denting the hypercytokinemia. The blue arrows when we gave imipalumab, and cytokines improved the next day. And again, within a couple hours of giving imipalumab, the patient was a lot better. Nurali has done a lot of work. She's the first person who pioneered really the use of anakinra in patients treated after CAR T cells, and there's lots of data using this for neurotoxicity. There's data using it for late CRS, and it seems to be effective in those scenarios. I think we need to do trials because it's not 100% clear how well it works for neurotoxicity, but there's enough of a signal that enough groups are using it in that setting. This was a recent paper that she published working with Caroline De Orio and some others. They basically summarized the anakinra experience across trials, and I'm not going to go through that in any detail. And then the other way one could think about targeting, or another pathway that, and another drug that gets a lot of interest in this room is actually using ruxolitinib and other JAK-STAT inhibitors. All anecdotal, but there are now more and more cases that are popping up in the literature where you have somebody who had severe refractory CRS, that they use ruxolitinib in that setting. My personal bias is that I worry more that using a JAK-STAT inhibitor would be more likely to impact the efficacy of CAR T cells than using imipalumab. I can't prove that. It's just because you're more globally hitting it, and it's going to, I mean, we use JAK-STAT inhibitors to treat T-cell mediated diseases. The other thing, though, is what we found in most cases of severe CRS, if you're critically ill and the horse is already out of the barn, there's probably not much you're going to do that's going to impact the CAR T-cells when you get to that state. And then the last thing I'll mention from Kevin's standpoint is he's going to talk later today about a nice model of IEC-HS or CAR-HLH that looks very similar to the models that often get presented for perforin mutant or HLH in babies, where in the CAR T cell setting, in the setting of high disease cell burden, attacking CAR T cells that causes some autoregulation, it causes hypercytokinemia, it activates your macrophages. And then there are many different ways that you could consider treating these patients who have severe CRS, especially refractory CRS. And I think there's more work to be done and a lot of drugs that are exciting out there. I did change one thing on Kevin's slide. It did have etoposide on there, and I got rid of that because I don't think we should be using etoposide in after CAR T cells. The other toxicity that we commonly see after CAR T cells is ICANS or neurotoxicity. Probably some of the best data out there in the biology of this comes from Crystal Mackle's group, where basically it's a combination of hypercytokinemia plus coagulopathy and endothelial disruption with probably some evidence of TMA. We've kind of looked at ICANS in that OLINK cohort I mentioned before too. This is showing some of that data where black, or the gray, is before patients develop neurotoxicity. Yellow is when they get neurotoxicity. On the left is patients who got neurotoxicity. On the right is patients who didn't get neurotoxicity. We looked at the IL-1 signaling axis after tisagenlecleucel. In some patients who get severe neurotoxicity, IL-1 goes high, but not in all. We did find that IL-18 and IL-18 binding protein reproducibly in every patient who got ICANS went very high, and it may be that the best way to treat this is going to be a combination of IL-1 and IL-18 blockade. We also found when we looked at our OLINK data set that a lot of these patients had endothelial damage and evidence of microangiopathy, high soluble C5b9, so there probably is some crosstalk similar to Crystal's data. And then I'll finish by just talking a little bit about just clinical cytokine profiling and how it can be helpful. So as I mentioned, at my center now, we're getting same-day turnaround cytokines. We actually started doing this because of the SARS-CoV-2 pandemic and the data coming out of China suggesting if your IL-6 is high, you may be able to give tocilizumab, and that can be of benefit. This is some data just looking at patients who are critically ill, trying to distinguish CRS from sepsis, very similar to Mike and Carl's work looking at HLH versus sepsis, where there are cytokines. Just interferon gamma and IL-1B can be used to distinguish between the two, and some recently published work. We did clinical cytokine testing on a lot of patients with SARS-CoV-2 during the pandemic, which could actually help identify patients with MIS-C. There was an outstanding talk on hyperferritinemic and cytokines after SARS-CoV-2, so I'm not going to go through this at all earlier today. And then just a vignette to finish my talk. This was a patient who had HLH from Ehrlichia. She had a very HLH cytokine pattern. She was treated with Ehrlichia-based therapy plus steroids and was clinically improving. And one morning, she clinically decompensated. And then the question was, is her HLH flaring? Should we give her etoposide? Should we ramp up her HLH-type medicines? Or could something else be happening? We sent cytokines on her. We, of course, sent a blood culture on her. We broadened her antibiotics. And before the Pseudomonas grew, which took about 24 hours to grow, we had the cytokine panel back this afternoon that actually did not look like her HLH was flaring. It looked like she had sepsis with a high IL-6 and a high IL-8. So we actually identified that she actually probably had something else going on that wasn't HLH before her culture turned positive. And this is a slide that I stole from Ed Behrens, that I think that there's more and more data coming out, and we have to understand more the interaction, the relationship, the spectrum of cytokine storm syndromes that are out there, from HLH to sepsis, and the host and environmental factors that are involved, and we have lots to learn. And this last slide is just showing CAR T cells that are currently in clinical development at least a year ago. Each one of those is a different drug or a different cellular therapy, and it just shows that the field is expanding like crazy, and there's a lot of work to be done. With that, I'd like to thank my lab. The people who are shown here are the people that are in my lab who did a lot of this work, and then also thank a lot of collaborators and people who have helped fund the work. And finally, the immune dysregulation program at CHOP, who helps us manage cytokine storm syndromes. Did I go over? The time has been at 14 minutes the whole time.
It's 2:26.
Ah.
I was confused too. Thank you, Dave. That was
Okay, so I'm gonna do it
fantastic.
2:26.
Do we have any questions? I think we have time for one or two.
I have a question here. Thank you, Dave. I was wondering, given the high rate of relapses with severe CRS, how much do you think is due to treatment that affects the efficacy of the CAR Ts?
So it's a great question. I mean, I didn't get into it in detail. It's really disease burden independent of severe CRS that correlates with the worst outcomes. So the patients with high disease burden, whether or not they got severe CRS, did worse. So now the question for that is that a biologic function of the leukemia that we can't get them into remission pre-CAR T cells, and that is a patient population that's enriched for badness, that's going to be less likely to respond to cellular therapy? Or is it the fact that you have more of a load, it's just too much for the CAR T cells to handle, and then a complex interaction there? But it isn't really probably an interaction with drugs, because they do worse regardless if they get critically ill or not. Again, Kevin's data shows that patients who get end organ toxicity do worse, so I think there is maybe something there, but I don't think it's treatment related.
So that was one of my questions. And the second one, in the same related vein, is could it be that the hyperinflammation itself is toxic to the CAR T cells and they don't survive? Do you have the data on that?
It's a good question. I don't have data on that. There probably is some feedback, and it could actually lead to the CAR T cells not proliferating as well, or at least not persisting as well. I think it is a complex interaction that people need to really understand. I think while it was hinted at in the literature for a while, I think it's really now just coming to light how that disease burden really does correlate with worse outcomes. So I think people are starting to really dive into the data and look at that more, but I don't think I've heard anybody who's put out a good definitive answer for it yet.
Great. Thanks so much, Dave. I think in interest of time, we have to keep moving on, unfortunately. The next talk is by Ulf Andersson. The outcome of macrophage activation syndrome is determined by the interplay between mode of cell death, HMGB1, and acetylcholine from the Karolinska Institute.
Thank you. And thank you so much for the invitation. The title of my talk is up there, and I'm afraid that this is something that thank you, a bit crazy. But what it is meant to cover is what is the contribution of the cellular victims in the disease? That is, the cells that were meant to die from an apoptotic cell death, but instead dies from a lytic cell death. I think that has not been so much discussed so far. And the other thing that I want to get into, if there is time, is what is the contribution of the central nervous system to the overwhelming inflammation. There are opportunities here for treatment, and there are opportunities to understand reasons for when an inflammation gets so overwhelmed. And this is also a rather an aspect that has not been so much discussed so far. My background is that I've been a pediatrician for almost 50 years. Most of that time I've served as a pediatric rheumatologist. But at the same time, I have done basic research in immunology together with Kevin Tracy at the Feinstein Institute in New York. Together, we 25 years ago discovered and explored two new fields. And that one was HMGB1 as an extracellular molecule as a prototype alarmin. And the other field is a cholinergic anti-inflammatory pathway. And I think that what I've learned from these biological basic studies are relevant to the topics we discuss here today, and that is what I want to talk about. I mean, this is then the major problem here. I mean, a cell is expected after a cytotoxic attack from an NK cell or a cytotoxic T cell to undergo an apoptotic silent cell death with no release of DAMPs or other pro-inflammatory molecules. But if this fails, that is underlying problem in HLA, regardless whether it's primary or secondary, then you will have a lytic cell death. And I've listed 3 of them here. There are more, but I mean, the major problem here is lytic cell death. And what is highly relevant in HLA aspect is of course the inflammasome-driven cell death, pyroptosis. And everyone knows about IL-1 alpha and beta and IL-18 as pro-inflammatory mediators released in pyroptosis. But so far I have not heard a single talk here mentioning HMGB1, but that is a major product released in pyroptosis. And in my little world, HMGB1 is the most important, the most interesting of them all, because HMGB1 is upstreams of all other the pro-inflammatory mediators here. And I will get to that later on, why I have this simple view. Yeah, well, I skipped this because this is so elementary. Well, cells that die a lytic cell death will release alarmins or DAMPs, and they are then preformed molecules doing one kind of job in the cell when the cell is in homeostatic conditions. But they will be released when the cell is stressed, activated, or is dying, and then they have pro-inflammatory activities that is quite different from what they used to do inside cells. They are chemotactic, they induce pro-inflammatory cytokines, and they modulate and activate adaptive immune responses. we are all very familiar with that gamma interferon as MAF, the macrophage activating factor that has been known since mid-60s, is a very important cytokine in HLH, yes. And I think it's fair to say that our host, Jan Inge, was the first one who described this, that in a small study here with 7 children, that all children with FHL, they had highly increased gamma interferon level. So there's no doubt that gamma interferon is an important player here. And this is then the scenario in HLH, that the cytotoxic cells fail regarding their ability to induce apoptosis, but they are quite good at all other tasks that they are meant to mediate, among them to release T cell products like gamma interferon. But this infected cell here, let's say that this is a virus-infected cell, that one will then undergo lytic cell death instead of apoptotic cell death. And then you have PAMPs from the virus and DAMPs from the cell, and then you get the macrophage activation. It doesn't need to be an infection. I mean, it's okay with a sterile setting too. I mean, if you have the CAR T cells and you have a malignant cell, you will get the release of the same DAMPs as you would if you had an infectious target cell. What is this? I would say the problem with high mobility group box protein 1, HMGB1, is a name. If it would have any sexier name, I think that it would be on everyone's lips. But it is. I mean, I've talked about HMGB1 now for 25 years, and I still stumble on the acronym here. So I mean, if it had been alarmin 1 or something else, then it would have been wonderful. But this is what it is. So it's a non-histone chromosomal protein. It has architectural functions in the nucleus, a DNA binding protein. It has expresses 214 amino acids. It bends DNA and enables access for transcriptional factors. And it is crucial. If you try to make global knockouts, it's a lethal thing you have performed. And it is extremely conserved during evolution. Every animal cell has it in the nucleus, even some plants. And there is 99% identity among mammalian cells. So I mean, this is really looks the same in wherever you look. And as an extracellular molecule, it is a prototype alarmin for reasons that I soon will get to. And this is what it looks. I mean, here you have resting monocytes. It is mainly present in the nucleus, but there is a traffic here between the cytoplasm. But it is in the nucleus. But if you activate that monocyte, or if the monocyte gets stressed in some way, then there is an active process of translocating the HNB from the nucleus to the cytoplasm. I mean, here I show monocyte, but it could have been hepatocytes, fibroblasts, neurons. I mean, this is the same process in all cells. Even platelets, which are without nucleus, have a lot of intracellular HNB1. This process to get it out depends on modifications of the molecule. It needs to be hyperacetylated to get out, and that is a JAK-STAT1 dependent process to put on acetyl groups on the lysine side. There are 43 of them in a protein with 214 amino acids, this is an important part that I also will return to. If you have too much HGV1 levels in an inflammation, you start with fever and anorexia. If you have more you have bactericidal effects, you get pain. It's a growth factor for certain cells, chemotactic activities, the activation of the endothelial cells and then leakage of the vessels. The same thing for the epithelial barrier with leakage, inflammation, and tissue damage, of course, if there's too much, and then you get organ failure and death in great amounts. And there are several mechanisms how HGV1 gets out of cells. I mean, I already mentioned that inflammasome-induced pyroptosis is one mode. But like IL-1 beta, it can be released in secretory lysosomes, although they come in separate granules. Platelets export extracellular vesicles. There are different active modes here. And then you have the passive. I mean, if you get necrosis, you of course get it all out all of a sudden. Apoptosis does not primarily lead to any release of HGV1. But if the reticuloendothelial system does not work properly, like in a flare of lupus, then you get secondary necrosis of the apoptotic cells, and then you get dangerous HGV1 release. We recently discovered an aspect that I think is extremely important, and that is that sensory neurons actively release HGV1 as a neurotransmitter. I mean, the neurosystem has has very defined ways to either promote or inhibit inflammation via neurotransmitters. Sensory neurons release substance P, GCRP, and HGV1, and to promote inflammation. And they release acetylcholine to inhibit inflammation. What is then the mechanism? How does HGV1 induce inflammation? There are two major pathways here. And one is a story that you know very well from endotoxin and LPS binding to MD2 in the TOL4 complex. HGV1 is a redox-sensitive protein. It has 3 cysteines, and you need the disulfide form. But then it binds, just like LPS, although at another site to MD2, and activates TOL4 the conventional way. This is in particular important in neuroinflammation, where HGV1 plays a major role in many neuroinflammatory diseases. The good thing here is that it is HGV1 itself that is the cytokine or the cytokine-like molecule, and that molecule can then be targeted via HGV1 binding antagonists. So that is one aspect. But I think in MAS and in many strongly inflammatory conditions, this is a pathway for strong pro-inflammatory cytokine release. And HGV1, extracellular HGV1, loves company. It is very prone to bind other molecules. like other PAMPs and other DAMPs. And those complexes get endocytosed, they bind to RAGE. There are many papers about signaling as a consequence of this. I think that is probably all true, but this is not the important part of it. The important part is that the complex gets endocytosed, and further on it gets to the lysosome, like any endocytosed molecule. And then we come to the really important part, the unique part about HNG1, and that is in the acidic environment in the lysosome, HNG1 acts like a detergent and permeabilizes the membrane in the lysosome. And the consequence of this is that the HNG1 complexes and the DAMPs and the PAMPs that HNG1 has dragged into the lysosomes will not be degraded. No, the partner molecules brought in by HNG1 will leak out from the lysosomes and get out into the cytoplasm and then encounter their sensors like C-gas, inflammasomes, RIG-I. I mean, these molecules that HNG1 bring in, most of these DAMPs like DNA, RNA, nucleosomes, histones, ATP, they are not dangerous as long as they are outside the cell, and they have no way of getting in there. But with this free ride of HNG1 and the damage to the lysosome, they get to the reciprocal intracellular receptors. And that is why I claim that HNG1 is such a uniquely important molecule in this setting, because they would not get in there. I mean, some of them generate antibodies, and antibodies will also bring them into the lysosome. But in the absence of HMGB1 in overload in the intralysosomal compartment, they will just be degraded. But if they get in here with HMGB1, then things get in trouble. Of course, this is not the physiological meaning. I mean, what we are talking here about is a pathological situation. What I think is a physiological meaning is that most of the molecules at HMG1 has defined binding sites to, like DNA or LPS. I mean, nucleosomes, histones, they are poor inducers of antibodies. So they bind to HMGB1, and if the system is not very crowded, then they will be degraded in the lysosome. There are two organs that constitutively express RAGE, and that is the endothelial cells in the lungs and the skin. And many other cells have RAGE in the cytoplasm, but it can rapidly bring it to the cell surface when needed. But the lung circulation is a location where this is constitutively present. And we have in trauma patients measured HNG1 levels on the venous and arterial side, and there's 40% less lower concentration of HNG1 on the arterial side. So HNGB1 and what is bound to HNGB1 is retained or destroyed, I mean, somehow stuck in the lungs. And my interpretation is that RAGE is meant there as a cleaning system for complexes in the lungs. But it may then have very deleterious consequences if there are high HMG1 levels and high levels of DAMPs. This is another example of what I've just talked about. I mean, we know that this is LPS is a dangerous factor in gram-negative sepsis, and we have been learned that TOL4 is what is needed here. But if you make TOL4 knockouts and you give them lethal dose of LPS plus type 1 or type 2 interference, they are as susceptible to death as wild-type animal mice. But if they are instead caspase 11, that is caspase 4 or 5 in humans, they stand any amount of LPS. So what happens is that LPS needs TOL4 on hepatocytes, and hepatocytes release HNG1 in huge amounts. Then LPS has 2 binding sites for LPS and brings in the complexes, and then then you have what I told you about. I mean, there will be activation of TOL4 in the endosome, but the important thing is that they end up in leaking lysosomes, and LPS will leave the lysosome and get to caspase 11, and then you have the dangerous things happening with pyroptosis and all the dangerous molecules, and you get phosphatidylserine transfer to the surface of cells, and induction of tissue factor, and that is how LPS induces a hypercoagulation. I think you are well aware of what is on this slide. I just wanted to point out that something that Tony Cerami pointed out already 30 years ago, and that is that corticosteroids does not work well as an anti-inflammatory agent in the presence of high levels of gamma interferon. I think that it's relevant to this discussion. And then I want to say something about etoposide, which, I mean, you know this, but I think what is then important from the aspect here of the victim cell is that etoposide then converts the lytic cell death in the target cell to an apoptotic cell death. So it's not only the T cell or the NK cell. I mean, the target cells are then tremendously important in this aspect. And I think this is. It's okay. Yeah, good. This is another study then from Jan Inge's group about the use of etoposide in I think 7 MIS children, and here is the study of ferritin as a readout, and then we have together studied or not. This is case reported of 4 children with very severe MAS, and looking on the results with HMGB1 glasses. And what you see up here is HMGB1. And all the 4 of them had sky-high HMGB1 levels in plasma and serum, and with an immediate drop when they got etoposide. I mean, this child had 150,000 in ferritin levels, and that was dramatically positive clinical results for all 4 of them. So, but what I want to say with this image is that when you look for it, you will find high HMG1 levels in HLA. And there are, if you convert well, HMGB1 is not a T cell product here. It's a sign of cell death, lytic cell death. And that is converted via etoposide. What are the opportunities to reduce or prevent the endocytosis of HMGB1 complexes? Because that has, of course, therapeutic interest. From a clinical point of view, this has been tried by Ben Liu's group in China, in Wuhan. He made heparin that was without anticoagulation effects, and that was beneficial in gram-negative sepsis. But you can make a truncated molecule out of HMG1, the box A, DNA binding box A, and in preclinical settings that works well in many severe inflammatory conditions. This is a problem. If you have antibodies against HMGB1, it will compete with the molecules already sitting on HMGB1. So if you are lucky, if you have a particular monoclonal antibody and there's not a molecule sitting where that is competing, then this may or may not work. So that's why I wanted to say that TOL4 dependent HMG1 pathology is possible to do something about with antagonists that bind to HMG1, but it is a problem here that you need, I think, some other way to reduce the HMG1 levels, and that is by preventing HMG1. We get back to that, because acetylcholine and GTS21, that is a small molecule binding to the alpha-7 nicotinic acetylcholine receptor, which is a receptor for acetylcholine to inhibit inflammation. They also prevent this endocytosis. And dinosaur is just a lab tool to prevent dynamine to act. And then I get back to the issue of the contribution of HMG1 from sensory neurons. We made first mice that were neuronal HMG1 knockouts. They had no phenotype when unchallenged. But then we did first sciatic nerve lesions, and then collagen antibody-induced polyarthritis, which is a severe transient form of arthritis in mice, destructive and polyarthritic. And the score in wild-type mice, which is a severe score, it was like this. But if they lacked HMG1 in the neuronal system, the onset was much later, and they did not at all get sick like wild-type animals. And this, what the Frey test here is about pain. I mean, wild-type animals had severe pain, and the HMG1 knockouts did not. So I think that they are not small effects here that we talk about the contribution of HMG1 released from neurons. We should. I mean, this morning Peter Brodin had a very interesting talk about systemic approach here to the immune system, but we have to include how does the immune system and the central nervous system interact in order to get things together. And this is another project that we have now spent almost 25 years on, and that is the cholinergic anti-inflammatory pathway. And that is exerted by the vagus system via acetylcholine and alpha-7 nicotinic acetylcholine receptors. We know about all this and the vagus system, but this was new when it was published in Nature 2000. And the way this works is that there is these two major vagal branches, cervical branches here, that ends up in the nucleus tractus solitarius in the brain stem, and each branch has 100,000 fibers. 80% of them are sensory. So the body, the brain is well informed all the time about what is going on in the periphery concerning inflammation. And then there is a motor when there's too much inflammation, then the vagus going to ganglion celiacus, which is very close to the spleen, will be activated. In the spleen, there's a switch to an adrenergic nerve, the splenic nerve, that then has norepinephrine as a transmitter that ends in many places and in the spleen. But what it does, it has nerve endings in the vicinity of T cells that has the receptor for norepinephrine, but above all, it has the enzyme for making acetylcholine. So what you will get out of this stimulation are mobile neurons. I mean, there are T cells that will leave the spleen and get to any part of the body where there is unwanted or too strong inflammation. So that means that it's not only area that is innervated by the vagus nerve that will be affected by the acetylcholine to inhibit unwanted inflammation. But what has this then to do with HLTB1 and I mean, as I told you, there is a need then for hyperacetylation of the NLS sites on HLTB1, and what alpha-7 nicotinic acid receptor signaling does is that it takes off acetyl groups from I mean, it takes off the acetylation from the lysins. So, meaning that by activating the vagus nerve, you can prevent active HMB1 release. That is a golden chance for novel therapy. I mean, we know from before that it also inhibits NF-kappa B activation, alpha-7 activation. But in the context of HMDB1, this is rather novel information. And it activates histone deacetylases like SIRT1. And that is the enzyme then that strips HMDB1 from its acetylation status. Well, we started the clinical exploration of this with like people have done for a long time in epilepsy patients with surgical inserted pacemakers and then electrodes internally on the left vagus branch. But and the first successfully rheumatoid arthritis patient that we treated was in 2012, and then there are a number of small studies, 20 patients in each study, rheumatoid arthritis, Crohn's disease, ulcerative colitis, lupus, demonstrating that many patients have benefit from vagus nerve stimulation. But it has the disadvantages of surgery. And I mean, if you already have a critically ill patient, I mean, you don't want to call a neurosurgeon to insert another device that is could I mean, where the procedure could cause a problem. But the interesting thing is that there is one place on the outside of your body, and that is in the Simba concha in each outer ear, auricle, that is innervated by vagus. And if you stimulate with the right parameters electrically there, you can activate the same centra in the brain as when you use an internal device. So this opportunity, this is something that I wanted to alert you about, that going for activation of vagus via 5 minutes of, I mean, in epilepsy, when they use it, they trigger 24 hours a day. When we've done the rheumatoid arthritis studies, it has been 2 minutes a day, not 24 hours. So it's very different, and the settings are different versus epilepsy. And here we have, in contrast to epilepsy, a rational, I mean, we know quite a lot of why this may work for certain patients. And this is a thought that I wanted you to think more about, that going this way to down-regulate inflammation via external transauricular electrical stimulation. And this is my summary, that H1 is a critical driver of excessive inflammation and coagulation in MAS, as in many other systemic inflammatory diseases. And reducing H1 release is a key therapeutic aim. And converting lytic to apoptotic cell death should be another aim. Propagating nuclear H1 retention via acetylcholine activation is maybe a chance to improve therapy, and that can be accomplished in a non-surgical needed procedure. Thank you.
That was fascinating. I think we have time for 1 or 2 questions.
Ulf, fascinating presentation. George Canarakis, hi. Can you see me?
Yes, yes.
Ulf, what happened to patients who had vagotomies for lots of reasons before we started to learn how to treat duodenal ulcers? A lot of patients had vagotomies performed, thousands and thousands of patients. Does that mean that they had a hyperinflammatory
I think
state?
that most have, I mean, it's not the whole vagus system that is removed. I mean, I don't know the English, can't recall the English word. I mean, they have selective. But I mean, we started to study this work via in the splenic setting, but the system is much bigger. I mean, it's a whole gut that has this possibility to react. I mean, it is so, and there you don't need any in between setting like a splenic adrenergic nerve. I mean, that can happen directly in the mucosa in the gut.
And also, does acupuncture work with this? Acupuncture work the same way? In other words, would that reduce HMGB1?
Yes, that has been demonstrated in many preclinical studies that they have even done it via external, in Kevin's group, external vagus stimulation in gram-negative sepsis, and the HM1 levels are strongly reduced, strongly reduced.
I think that was fabulous. I think our time is unfortunately up, and it's the coffee break before the presidential session. But I want to thank our speakers again for just a really stimulating and interesting session. Appreciate it greatly.
Thank you.